Hello, I'm Tamara Padgett, and I will be presenting pulmonary embolism, case study number 9 for Nursing 711 Advanced Physiology and Pathophysiology. VA is a 30-year-old female, presents to the ER with 90-minute history of sharp and consistent right-sided chest pain. She's also having some right-sided mid-back pain, and she's rating the pain about an 8 out of 10. It's worse when she takes a deep breath or when she tries to lie down, but when she sits up, it is a little bit relieved. She also reports having difficulty breathing, and she is a very busy executive and just returned home from a flight from Tokyo, which was a 13-hour flight. She also has a history of pulmonary embolism. With pulmonary thromboembolism, also referred to as PTE or PE, there's a venous thrombi, a blood clot, usually deep vein thrombosis or DVT. It detaches from their site of origin on a blood vessel wall, travels through the blood to the lungs, obstructs blood vessels, and reduces the blood flow. Then damage occurs, as you can see in the picture there. The clinical manifestations depend on the size of the embolism and its site of impact. Large emboli can be fatal. Most emboli are multiple, so multiple pieces of the large DVT break off, and the lower lobes of the lungs are more commonly involved due to more extensive circulation. This occurs in about 10% of people with DVTs, approximately 900,000 cases in the US every year, which is shockingly high. I think there are 50 to 100,000 deaths annually, and all races and genders are affected the same, but there is a higher incidence during pregnancy and with contraceptive use, which means women are more affected than men, as most men are obviously not becoming pregnant or using birth control pills. And the key signs and symptoms are the dyspnea and hypoxemia, along with that sharp stabbing pain, difficulty breathing, and sharp pain with intake of breath. The three factors, collectively known as the Virchow triad, is what is thought to cause pulmonary embolisms. This is venous stasis, like sluggish blood flow, hypercoagulability of the blood, and injury to the endothelial lining of the veins. You can see, again, in this description picture, how blood clots form. This patient did have venous stasis from her long flight. She also had some dehydration and the injury to the cell wall. It doesn't seem like she had any, but clearly something had happened. Our assessment data. So the physical exam is unremarkable, including no jugular venous distension. Lung sounds are clear and not diminished. She does, though, have prominent saphenous vein that's visible in the left leg with multiple varicosities bilateral. Her peripheral pulse is 100. Her chloride is 110, which is high, along with low hemoglobin of 11.9 and low hematocrit of 34.8, which would point to her being dehydrated. Obviously, her PTT is mildly elevated, depending on which scale that you're reviewing. Both her right and left lower extremities show abnormalities of the venous narrowing, prominent collateral vessels, and incompressibility of the deep venous system in the popliteal veins, which are findings that are consistent with bilateral DVTs. There is a perfusion deficit at the right base, which shows a VQ scan mismatch between the perfusion abnormality and ventilation of her right lung, which really does show a strong suggestion of pulmonary embolism. Her pulmonary angiogram showed an abrupt arterial cutoff in peripheral vessel in the right base, which is definitive of a pulmonary embolism. Otherwise, to note, she is positive for protein S deficiency, which is a clotting abnormality. She has a history of DVT 2 years ago. She was treated for with warfarin for 1 year. She does smoke and she does take birth control. With her history of having a DVT, taking birth control pills and smoking, I'm very surprised that her physician prescribed her birth control pills, as she has so many risk factors. Role of the APRN is to be, of course, an emotional support, educate her, educate on her risk factors. Her smoking cessation would be very helpful for this patient, as well as stopping the birth control pills. Treatment for this patient, normally a treatment would be 3 to 6 months, but since she has recurrent thrombi, at least 12 months of treatment is recommended. And as a Christian practitioner, you would want to ask her how her faith impacts her life and how her faith helps her view this diagnosis. And we can comfort her with the Bible verse, cast all your anxiety on him because he cares for you. We would, though, however, make sure to avoid imposing religious views, but respond to her cues about what brings her comfort. The questions for this case study are if the clinician had observed significant jugular venous distension, what is a reasonable explanation for that finding? The second question is what might the patient's chest x-ray reveal if she had one? And would you suspect that this patient's plasma D dimer concentration is negative or elevated, and why? And here are my references. I hope that you enjoyed this PowerPoint presentation over pulmonary embolism and that you found it to be educational. Have a great day.